There's a lot today. I'm going to miss you tomorrow. Nothing with you tomorrow. Got lecture today and Clean Skills Lab this afternoon that I'll be on for probably the 8 of you that are going to go. I know the psych test is tomorrow, all right? I fully expect 3 of you to at least answer any of my questions with cognitive behavioral therapy today. It's okay. I get it. Not computer-based training. Those are different CBTs. Do not prescribe your patient computer-based training. That will not help them. I won't watch that. If anything, that makes me more depressed. Right? That goes against anything. I don't know how it is in the Army, but the Air Force won't do that. And the Army started doing it too now, where like you can't just click through the slides anymore. Like they force you to like listen to the person talking. You can't hit next until it's done. That's miserable. And if you click off of it to go do something else and it's not on the forefront, it stops playing. Getting smarter, man. Forcing us to sit through 6 hours. U.S. constitutional awareness test. All right. This is where we left off with the shoulder. All right, we're gonna do a couple more things. I had some good questions yesterday, kind of after class, about this viewpoint here. And I'm going to kind of touch on it just a little bit now. I talk about it in dislocations, but it's really important in dislocations, right, to determine the anterior versus posterior. Don't forget to look for fractures and stuff in this too. I know I talk about it mostly in dislocations, but still go through your systematic process, right? Why is it so important on this image to question I had to really understand the coracoid and the acromion, right, for that anterior versus posterior? The reason this is so important is this is one of the few images that I can't promise you is always going to come across the screen in this direction, okay? Because it's just leaned up and they take the picture either from down or underneath, right? So this might come across completely 180 and where the humerus is pointing up. This might come sideways, right? There is no like general rule of how the axillary shoulder x-ray comes across. So unlike the scapular wide view, which always is going to come that way because the patient is upright, I can be like, hey, if the humeral head's in the thorax on this side, it's anterior. If it's in the soft tissue, it's posterior. Here, I can't promise you where anything is going to be on this x-ray, which is why you need to understand the clavicle and coracoid area and the acromion and scapular spine area, because that anatomy, if you understand that, will help you understand whether it's a posterior or anterior dislocation, okay? So that's kind of why I believe that specifically on the anatomy. It was a good question yesterday. I don't remember who it was, but maybe I'll kind of explain that a little bit more. But more shoulder x-rays. Pediatric or adult? Pediatric. Okay. If it says normal, and there's what looks like a fracture, it's a growth plate. Right? Good. So this is what a pediatric normal shoulder x-ray looks like. That is normal. Okay, pay attention to that being normal because there'll be one where it doesn't look like that. That is an abnormality, and we'll explain that a little bit later. Okay, that is normal for a pediatric shoulder X-ray. Other than the growth plate, it's very similar to the adult one, except for bones are just smaller, right? And there's a little bit more, like it's not as overlapping here in the glenoid fossa and the humeral head as the adult because it hasn't all come together yet and gotten bigger. Okay, here's what an MRI looks like. Normal MRI, what I highlighted there is the supraspinatus tendon, okay? And then that nerve and vascular bundle there, that's why that's all white, that's fluid and nerve and vascular bundle. Graded tuberosity, this is just normal MRI. Not gonna make you read the MRIs, all right? You can see though how we can see the labrum quite nicely in here when we do the MRIs. This is why labral tears require an MRI. However, as you're learning now in Clin Skills, and as you will learn more in ortho, you do not need imaging to diagnose a labral tear. You have special tests that lead to your suspicion. So when do I order an MRI in the shoulder? When my special tests make me think there's a labral tear, not because the patient wants one because their shoulder's owie, right? They're all going to want one because their shoulder is owie, and they just think they need an MRI. That's why you have physical exam skills. Right? And same thing with the knee and the meniscus. When you did that next lecture, the Apleys or the Thessaly or the McMurrays, the ones that, like nobody likes McMurray, just do the Thessaly, guys. Like, I mean, you have to learn it all here. When you're in clinic, just do the Thessaly test. It is the one that is almost, if it's positive, it's positive. Just don't let your patient hit the floor when they're hurt themselves. Because if it's positive, they're going to drop. Just painful. Anyways, this is just showing you kind of what an MRI looks like. You're not going to have to read those in clinic or really on this test outside of what I talked about with the spine. Okay, but you do need to know that you're looking at an MRI versus a CT. What slices do we have here? Let's go with the one on the left. Why does he keep asking us this? There's a reason. Coronal. What about this one here? Good. That's an axial slice. Excellent. Get ready. Give me a test tomorrow morning. It'll be fine. No? Okay. All right. Shoulder dislocations. We've been labored shoulder dislocations as far as how to look at it on X-ray, right? What's the pathophysiology behind it, right? Mostly are going to be anterior. Mostly going to be anterior. And that's just because of how we're structured. There's a lot more room for it to move anteriorly, right? If I'm going posterior, I got a bunch of muscles back here, I got a scapula back here. There are things that kind of stop it from dislocating posteriorly. It takes a significant kind of force and trauma to the anterior portion to make it posterior dislocate. So your most common dislocation is going to be anterior. Typically what happens is they fall on an externally rotated, right? Abducted, extended arm, so throwing and falling, right? It's going to pop out anteriorly. That's the most common way for it to happen. Or usually what happens, they're not usually throwing, but as they fall, they're like, ah, and they line with their shoulder and it pops out. If you're going to do a posterior dislocation, right, less than 4%. Now I recognize that 90% and less than 4 don't add up to 100, right? Don't ask me, it's medical math. I don't know. Just know that less than 4% of shoulder dislocations are posterior, right? And usually seizure related. That is something that can cause that. The seizure related, because the way all the muscles kind of seize up and pull back and forth and shake and stuff like that, or they seize and then they fall out of a bed or off a couch or from standing or something along those lines. A lot of times your posterior shoulder locations are related to a seizure. Here's your inferior dislocation. We haven't talked about it very much because it's less than 0.5%. Still not 100, but gives you an idea on that, right? The nice part about the inferior dislocation is you don't need an X-ray, right? That bottom line, patient presents with locked forearm to forehead position, unable to move, right? I can't even really do it because my shoulder is not dislocated, but if you think about an inferior dislocation, the humeral head's coming straight down. Right? And so the arm is up like this, and they're not moving that, they can't move that arm. You'll probably see the humeral head kind of almost in the axillary region, you'll be able to feel that, but they can't move this arm. You don't need an X-ray to determine this. Like, this is the only one that presents like that. So that really is going to be a clinical thing. The biggest concern with that is the line right above it is that you're probably going to have a fracture, obviously rotator cuff injury, but this one has a high incidence of neurovascular injury, right? Because we got that big neurovascular bundle sitting right in that axillary region, has a high incidence of that. But your anterior is your most common, okay? Your posterior, a little bit less, but it's still be possible, and very rare for the inferior. So you shouldn't suspect it unless there's trauma, unless you see a descendant of Harry Houdini. Just wear that little straight jacket thing, you see the magician thing, they always pop their shoulders outside. But the shoulder joint by nature is one of the more unstable joints in our body, right? The only thing that's really holding it together is all the muscles, for the most part. The humeral head sits in the glenoid fossa because it's just nice and it sits there. There's really no ligaments or anything connecting that humeral head to the glenoid fossa. There is for the AC joint, but not for that actual shoulder joint. It's all based off of that shoulder girdle, okay? And then even then, when it does articulate, only 20 or 30% of that humeral head is articulating with it. It is not a stable joint. It is probably one of the more common dislocated joints in the body. Let's see. So signs and symptoms, right? Pain. Humor is not where it's supposed to be. In reality, a lot of these things are going to dislocate and pop back in. So you'll probably be seeing the patient after the fact. A lot of times we'll do that. Arm locked in place if it's not after the fact. X-ray study. X-ray is your study of choice, right? There's your standard views we've talked about. The AP, the axillary, and the scapular Y. Again, recognize you don't need both the axillary and the scapular Y. You'll need one or the other to determine where it's dislocated in which direction. It says often need to get pre-reduction films, which means Maybe you need to get them beforehand, but again, when you see a shoulder dislocation, you may not need to get an x-ray in the beginning. You can tell it's anterior dislocated, posterior dislocated, inferior by looking at the patient. You go back to that one slide where we showed that the techniques of how to kind of pop it back into place. If you can tell physical exam-wise that it's dislocated, go ahead and pop it back into place. But you must always, always, always get post-reduction films. Always. You may not need to get it beforehand because you can tell, but you have to get post-reduction films. Why? Right? Make sure it's where it needs to be, but then you're looking for any fractures that may have happened from the dislocation. May not, and then let's say you get the pre-reduction films, you're like, oh yeah, it's dislocated, right? And there's no fractures on it. Still got to get the post because you could have fractured it by putting it back into place. Right? That can happen. And we'll look at a couple of specific fractures that happen due to shoulder dislocations. So always get your post-reduction films. And that goes really for any dislocation that you're resetting. You should always do it. Even if you got a displacement and you're resetting the bone back so it can, I feel like they go into ortho so you can cast it and let it heal and everything, still get your post-reduction films. All right. Speaking of those fractures, Hill-Sachs deformity is on this posterior lateral portion of the humeral head. Now, everything we've looked at before, let me go back to our normal x-ray a little bit. Let me find it. Here we go. Right? We have this nice rounded humeral head. Yeah, we got a little bit of a divot there, right? But nice round kind of humeral head. That's what we should be seeing. When we get to these Hill-Sachs lesions, look at the significant drop-off we have on this way. Ignore the white arrow for now. Look at the black ones. Okay? Another one down here. This is not nice and round. So what you have here, and look at this dislocation one down here. So this is your pre-reduction films. It looks okay. But then post-reduction, look what we got. So the Hill-Sachs fracture is that fracture on that posterior lateral humeral head, typically impacts the anterior glenoid rim, and it causes a divot in that humeral head. Think, I got it right there, top of the hill, right? I'm on the hill, I'm on the top of the humeral head, that's where my Hill-Sachs fracture is going to be. Okay? Now, why is that important? Well, if I did the dislocation, then I'm going to be looking for it. Well, we might get a patient who dislocated their shoulder as a kid, dislocated it as a young 20-year-old, right? And you're seeing them now at 35. They never went in. It popped out, popped in. They were fine. They were sore. They did their thing. 12 years later, they got shoulder pain. You're looking for it, and you see this. Now, if they haven't recently dislocated their shoulder, that's probably not an acute finding, right? So then your next question becomes, you ever dislocated your shoulder? Oh, yeah, I've done it once or twice. Okay, that's probably why you have that Hill-Sachs lesion. I have one of these. I don't remember dislocating my shoulder, but I must have when I was a kid. A couple of times. I was pretty active. But that's what happened to me. I had shoulder pain. I went and did an x-ray. They're like, you have a Hill-Sachs. I'm like, wow, I never did that. So it must have happened at some point when I was a teenager, doing all my sports and stuff like that. But I don't recall it. All right. So then we have our Bankart lesion, which is on the bottom, right? The anterior inferior aspect of the glenoid rim. Okay? B for bottom, B for Bankart. All right, I love simple. I'm a simple person. All right, if I can associate it with something simple, then we're good. So B for bottom, B for Bankart. This is on the inferior aspect of the glenoid rim. All right, most commonly from an anterior shoulder dislocation, because of the way it comes out and goes back in, I'm hitting that glenoid rim, and that's really what it is. It's bone on bone and a force. Okay. So these are your two primary fractures looking for on a shoulder dislocation, your most common fractures. Yes, you can have a rotator cuff injury. Yes, you can have a labral tear. Yes, you may find that at MRI, but you're often not going to order an MRI for just a standard shoulder dislocation unless your special tests are positive. And here's what I will tell you. If you just reset the shoulder, special test, probably not a good time to say, oh, that's positive. Now, if they're already in pain, right? Give them a week or two to heal up from the dislocation, bring them back in, then do your exam, and then if you get a positive test thinking about a labral tear, go ahead and order the MRI. But everybody's going to be in pain after you reset a dislocated shoulder, right? So Hill Sachs, Bankart. Questions on those two? Hill's top of the hill, top of the humeral head. H for hill, H for humerus. B for Bankart, B for bottom. Glenoid fossa, or glenoid ground. Okay. Here's another slide to break down that scapular Y view, and now we start to see some of the abnormalities. So, normal x-ray, if it's within the thorax, it's anterior. If it's within the soft tissue, it's posterior. Down here, we have normal, sitting right in the meat or the main part of that scapula right there. Yes, it's not perfectly in line, the scapula with the humerus, like it kind of is here. But the humeral head is sitting in the main portion of the Y of the scapula. Here I'm posteriorly dislocated. Here I'm anteriorly dislocated. Now, I respect the fact that there's no thorax here. So how do I know that? Again, knowing your anatomy and where the Y sits and how we've learned this, and it's always going to come across this way, looking at your anatomy. If it's this way, it's anterior. If it's this way, it's posterior. Does everybody see that from the scapular Y view? If I give you just the Y view, do you have enough imaging to determine anterior or posterior dislocation? Yes. If I give you just the axillary view, do you have enough to determine it? Yes, but not the AP. The AP is not enough. You need a second image. Good. And this is where I go into more pictures. Look at my AP view. Definitely dislocated. Now maybe if you're like, well, I don't know what part of the glenoid and the humerus is supposed to articulate. Is that normal? Is it not? I refer you to when you get to your systematic process of looking at joint spacing. Right? Maybe joint alignment, you're like, I don't really know. But joint spacing, right here, in between the humeral head, right, and the acromion there, that is a much larger joint space than you should see. That's your hint that it's dislocated. Right. As you get better at this, as you see more of these, this part you will pick up on, and you're like, I don't even need the spacing. I can just see it's dislocated because of that. But at your level, maybe not, because there is some overlap, right? There is some articulation there. Is that right? Is that not? Joint spacing. So if you go through your process, you will find that abnormality. And then we go to our Y view, and we see it's in thorax. So we have an anterior shoulder dislocation. Here is your pediatric. Pediatrics are a little bit trickier. But what is normal about the growth plate on a pediatric shoulder x-ray? It's got this nice little point, like the other one we looked at. All right? It's got this nice triangular point. That is normal for a pediatric shoulder x-ray. If you're ordering a pediatric shoulder x-ray and you have a horizontal growth plate, that's indicative of dislocation. Also, a little more advanced, look at the joint spacing here compared to here. There's a larger joint space, right? But for you guys, what I would say is, look at that growth plate. We know what normal is by seeing that triangle. We've seen multiple pediatric shoulder films, and that growth plate is supposed to have that nice little triangular area. So when we have horizontal, or light bulb sign, right, is what some people call it, looks like a little light bulb, that is abnormal. That's your sign that that's dislocated in a pediatric. Okay. Big red circle. Are we anteriorly or posteriorly? Oh, it's on the slide. Dang it. I gotta take that off there. Posteriorly dislocated. This is meant to show how the Y view matches up with the axillary view. Right? And really, I want you to focus on that axillary view because it can be really difficult to look at. This is what I was talking about, how they're in different areas. If I just turn around and say, hey, it's pointing towards the top, it's anteriorly dislocated. Not with the axillary view. Use your anatomy to look at that. Here's my acromion, here's my coracoid, my clavicle. This is actually posteriorly dislocated. So these axillaries can come across in multiple different ways. It's just the nature of the x-rays and kind of how they do that. This will always come across vertical, okay, for the wide view. So you can safely use the thorax versus the soft tissue. Questions on that? Yes, please.
Can you go back to the axillary view and explain that one more time?
Which one? This one here?
Yes.
Okay, so explain why it's posterior.
Yeah, I see why it's posterior.
Okay.
I just wanted to make sure. So you said behind
the acromion,
yes,
right, and the scapular spine.
Okay.
And so since it's shifted past the acromion and the scapular spine, that's posterior. Here we have the coracoid and the clavicle. Coracoid and the clavicle. Right? So that's an anterior anatomy spot. So if the humeral head was shifted down past here, it's an anterior dislocation.
Thank you.
You're welcome. Does everyone see it? If you don't see it, let me know. We can kind of look at it some more and kind of go over it again. And that's why the anatomy for this is really important. Another trick I use for the axillary, right, when I'm looking at the bones, because it won't be labeled on the exam, won't be labeled on your real x-rays, right? The acromion is crooked, CR. Acromion curves, it's crooked. Acromion's crooked and curves. The clavicle and the coracoid do not. Right? So that's me. If that works for you, great. If you have a different way of looking at it, that's fine too. That's the way I always kind of look at it, because the coracoid just kind of comes out right here and just sits. And even the clavicle, when it gets close, so is that acromion or clavicle? Well, the clavicle just kind of comes right out straight and stops. But that acromion always has that curved kind of bone nature to it. Or it's crooked, it's not just straight, right? So I use that ACR, CR to help remember which one the acromion is. Simple man, I like simple things, but. Yeah, it's because the outline's right on the bone. Let me go back to here. So again, I have the red line, but see how it comes down and it curves in? So the acromion, I'm going to trace it here. Do I have another one? Ah, beautiful. So I'm going to trace the acromion here. It comes in and it curves up underneath that humeral head. Okay? So it comes in and it curves up. So it kind of goes here and around here. Whereas my coracoid just sticks out, or my clavicle just comes straight down. Coracoid, clavicle, acromion kind of comes out and curves on this view. I have another one. Here's another good one with the outline, right? So you can compare the outline. I'm going back now for those of you who are following on the slideshow. I've gone back. The acromion comes up. Here it comes up right here. Okay? Whereas your coracoid sits up here. Clavicle just comes down here, but really that acromion kind of does that little, almost looks like an L shape in this direction, right? Like a backwards L, but depending on the direction it comes in, it'll be a little bit different. So that's, like I said, that's how I remember it. Now I can't say, look, it overlaps here with the humeral head, because when it's dislocated, it's not going to be overlapping anymore. It's out of place, right? So that's why I don't use that as an example. Like, look, the acromion overlaps the humeral head. Well, when it's not there, it's not overlapping anymore. So I use that kind of crooked, curved aspect of the acromion to help me understand where it's at on the x-ray. Does that help? Okay. Okay. So normal, this is another axillary view that's pointed upwards. Okay. Another axillary view that's pointed upwards. What this is trying to show you is this is more of a post-reduction, but this is showing you the fracture, the Bankart lesion on the axillary view on that glenoid rim. And when you compare it to the normal, I have that nice cortex there, right? Nice joint spacing, nice cortex comes down. I can follow it all the way down, but I got this break sitting right there. Big white arrow on the glenoid fossa. Now you're going to see that a lot better on your AP view post-reduction, right? But you can see it on the axillary, so I want to point that out.
Can you run through the bones, like the landmarks on these?
Sure, which one?
So the
they're a little bit different.
clavicle's obviously coming down.
So you got humerus head here, right? Humerus here. Acromion. Now it's opposite here because this image is flipped. Acromion. So if you stick with the curved or the crooked, you'll never get it confused. Coracoid's right here. Coracoid's right here. Pop over here too. Coracoid. Coracoid. Acromion. Acromion. Scapular spine. Glenoid fossa. Scapular spine. Glenoid fossa, scapular spine, okay? And your clavicle is actually kind of, it's really distorted and weird. So don't get hung up on the clavicle, but that's kind of what this bone is right here and right here. But it's not a good view for the clavicle, so like I wouldn't use this to evaluate a clavicle, which is why we don't have this as part of the clavicle imaging, because it doesn't give you a really good picture and it kind of distorts it. Did I hit all the bones you were wondering about?
Yes, sir.
Okay, perfect. Other questions? If I'm asking you to pull out a bank heart lesion, it will not be on an axillary film. It will be on an AP film, okay? I'm not that mean. I know some people think otherwise, but I'm not going to put it on an axillary film. It's going to be on an AP film, okay? If I actually pull that out. Here's another Hill-Sachs lesion with a very subtle bank heart lesion on the bottom. I will also try to make it more obvious. Very subtle. But why do I show that being subtle? Because if you know somebody dislocated the shoulder and you reset it or you're evaluating them, right, it should be a closer look to make sure you're not missing anything. Now, if you don't see it here and they come back in a week or so and you get the x-ray, it'll probably stand out a little bit more. Right? I recognize that that bank heart lesion is very, very small. Very difficult to see. But the Hill-Sachs, yeah.
We usually see these at the same time.
You can. It can be, you can see both, right? Often you do see both, but there are, right, it depends. There are multiple times where it's just one or the other, right? I will say in my clinic, and this is just clinically speaking, anytime I've seen a bank heart lesion, I've seen a Hill-Sachs fracture. However, I have seen Hill-Sachs without bank heart lesions before. And I'm sure if you pull all the instructors here, I'm sure there's some that have seen a bank heart without a Hill-Sachs. It just depends on the person and the mechanism of injury. But if I see one, I make sure to look deeper for the other to make sure I'm not missing it. Yeah, no, this is normal. Thank you for asking. This is normal. There is no fractures on this guy right here. And really what the arrow's a little off, but really we're looking at the bottom part of that glenoid rim and it kind of has a fracture right there. If you look at normal, the bottom part of the glenoid rim is right there, and then we have that gap right in there. Again, hard to see on this one, I recognize that. Use Radiopedia, look up bank heart lesions specifically, look up Hill-Sachs fracture specifically. Radiopedia's got some really good ones on there. I don't put a lot of the Radiopedia ones on here, because again, one of the things I say is if it's in my slideshows, it's not in the test. So if I pulled everything from Radiopedia, then that would be difficult for me to find things to put on the exam. Yes?
Just to clarify.
Yeah.
The bank heart lesion is like a line, like the little.
So it's more the break in the cortex that's right here above the arrow, right? This is hard to see, right? I originally pulled this for the Hill-Sachs thing and then was like, hey, all right, I gotta put that on there too, because people will be like, hey, I think I see that. I'm like, okay, yeah, I gotta label that too as well, yeah.
Black triangle?
That's all just, this whole thing is the Hill-Sachs fracture. Yeah, it's this whole thing. It's not just here, because some people will look at it here and just see like this little break and be like, oh, it's there. No, it's showing you that it's this whole area. It's kind of a double, yeah. Sometimes it can be one, sometimes it might be a double thing. It just all depends on how I got injured. Yeah. So, MRI arthrogram, right? Not testing you on this, but basically what we do here, and I think I briefly mentioned it, when we're looking for a labral tear, what happens is the patient gets a contrast injected directly into the labral area, into the joint, then they go for an MRI and they scan the MRI, okay? And so what you're seeing here is I show you an abnormality. So here I got my supraspinatus tendon, the gray fibers all kind of coming together, okay? Everything looks nice and intact. Got a little spacing here around my labrum, my glenoid fossa, and then when I come over here, under, again, a difference, the T1, T2, so it's a little bit different. When I come over here, I got supraspinatus tendon, and there's my tear. That's what the black is. There's my tear. I got a little bit of fiber here at the bottom, so maybe it's not completely torn. Maybe it is. I'll wait for the radiologist to tell me if that's a full thickness tear, if that's like a 95%, which means they're going to call it a full thickness tear. But this goes to show you how the MRIs can be helpful when it comes to those rotator cuff tears. That's what makes that stand out. You won't see that on an X-ray. Not going to make you diagnose this. FYI. But you will see these in ortho. This is a reminder. Your left is their right. Your left is their your left is their right. Your right is their left. And do not pay attention to the confusing man behind the curtain. In other words, backward L's and R's. It doesn't mean anything. Remember how I told you, they asked the question like, well, what happens if they're EPPA, turn around, that kind of thing? How they always naturally will flip it to the way it's supposed to be. You'll get backwards letters for left versus right markings when they take the X-ray, and it was maybe that opposite way, and then they flip the image so it's the way you're supposed to be. Well, the marker they put on there, it's imprinted, right? So that flips backwards as well when they flip it. So that's why if you see the backwards, just know it's still right and left. It's still labeling the correct side of right or left. Don't worry about the fact that it's backwards. In fact, people get confused and well, it's backwards, so I assumed it meant no, left means left, right means right. That is the side. But because they do that standard operating procedures of flipping images to make sure it's correct for you guys and all of us, sometimes that burnt in right and left marker flips backwards when they flip that image before they send it over to you. So that's why they're both on the same side. It does not matter how the letter looks. All right. The humerus is very similar to the thoracic spine. It is very short. It's very simple to go over in the aspect that there is not much. It's just one long bone. All right. One long bone. There's your anatomy. Here's your X-ray. Why do you think I have this red line cutting off right here? Anybody know? So it's close to where the elbow's at in the forearm, right? Oftentimes what will happen, because the humerus can be a longer bone, you'll get all this lovely stuff and then it stops right here. It is not a complete X-ray unless you can see the joint above and below the bone that you are looking at when it comes to our extremities. So if it cuts off here, you need to contact them and have them do a repeat. Because if I can't see the tip of the radius and the ulna, I haven't captured the entire humerus. There's a portion of that bone that I'm missing. So that's why I have that line. Like, so a lot of times you'll get this, especially in the larger folks or taller folks. They miss it. Redo it. So, but here's your anatomy, right? The biggest thing on this is going to be shoulder dislocation. We already kind of talked about looking for any fractures there, looking for down here, and we just got one long mid shaft of the bone. Here's your lateral, same concept. If I don't have both elbow and shoulder joints, it's not big enough. This is your anatomy here. These guys, medial and lateral condyles, are going to be superimposed. This is not a good picture to look for posterior fat pad. Why? It's too wide, it's too big, it's not detailed enough, right? Even if I have a small radial fracture or a small elbow fracture that I can't see, maybe if you're lucky you might see that posterior. You're not going to, most of the time you're not going to see it on this one. Because your primary portion of your x-rays are right in the center and they're focused here. And you get those divergence that goes down, right? Primary portion's here, and then you get divergence that comes up and down. That's why this is so much whiter, because there's a lot of bone in here superimposed, and they have the weaker radiation getting to that area, so it's a little bit brighter. Which is fine, because I'm mostly concerned about the shaft of the humerus when I order a humerus x-ray. Very rarely are you ever going to order a humerus and not order a shoulder with it, right? Or maybe even an elbow with it. You always get usually one or the other going with the humerus. So that way you don't miss anything. Pediatrics. So you know what pediatric ones look like. I don't have a big humeral head. Oops. Little humeral head right there. That's it. That's it. It will grow. It will get bigger, right? So again, if I give you something like this for a pediatric, it's going to be pulling out a mid-shaft fracture or something along those lines because, right? I don't even know how old this one is. I don't know when they're supposed to heal or like fuse together. It's way too advanced. Okay, so now let's compare some normal to some abnormal humerus x-rays. Not funny x-rays, x-rays of the humerus. Big yellow arrow. Okay. So if you follow your cortex, right, this is my normal. Follow it up around, look at my medullary canal, look at all my joint spacing. Now let's go back to what we thought about that dislocation, right? Look at my joint spacing up here. That's your hint, that big gap that we saw before. Not necessarily the overlap, because that kind of looks like the same amount of overlap as that one dislocation. In a different section of the humeral head, but very similar percentage of overlap on the x-ray. But here I don't have any of that large joint space that I had on the abnormal. So, normal. And then when I follow my cortex up and around, well, I got a break there. I got a break there. I got a little sharp there. So follow my cortex around. I definitely got a break in the cortex there. And then a break in the cortex there. Now maybe this is a spiral, maybe it's not. I can't really tell 100% with just one image because it almost kind of looks like it might be shortened too, because it almost kind of looks like the humeral shaft kind of comes up into where the humeral head is, right? There's not enough images for me to expect you to pull that out. Find the fracture? Sure. Know that it's shortened or rotated or whatever with just this picture? It's not enough information. I don't know yet. So for those that saw that and were wondering, is that shortened or not? Maybe. It's possible. You would need other images, and primarily, if I give you that lateral wide view, actually, that would probably give you a really good view of whether or not that's been shortened or not. All right, so here are two types of fractures of the humerus. One is a straight oblique down here, or I got that right. Do that one too well. No, it won't. I don't think so. Anyways, I got the oblique here, and then I got my spiral up here, rotational force. Now again, there's two ways to tell the difference between these. One, mechanism of injury. If I tell you it was a rotational force, but then two, look at the, I'm going to call it the depth, the different layers in the fracture. Here I got a clean fracture with two pieces of bone, probably 3 or 4. It's probably common unit if you get into all the little details there. But I got the fracture there, maybe an incomplete fracture here coming through. Now, if I have an incomplete, and then in the same bone I have a complete, you just call it a complete fracture. Right? We're not going to play the game of having both in one x-ray. Once something's through all the way, it's a complete fracture. But then when I go here, I got my medullary canal, I got my cortex, and I have like the cortex, and then almost like this other deeper layer from that rotational, that twisting force that kind of twisted and broke it apart. Okay? Can see it a little bit down here on the inferior piece of the superior humerus. Kind of see it just a little bit down here. This x-ray is from this, an injury from this kind of event. I don't know how many of you have ever watched like the World Arm Wrestling Championship things. ESPN 8 the Ocho, or whenever they show that kind of stuff. Or like the slapping challenges. Yeah.
I got a question.
Go
So
for it.
on that oblique fracture,
Yes.
So you're saying there's possibly an incomplete fracture.
Yeah, maybe right here.
Yeah, if it was a clean, like it's all the way through, just two pieces, but we also have an incomplete fracture, does that make it convoluted?
So it does not, because that incomplete fracture is still one piece, because it hasn't gone all the way through. Which is why when we talk about simple fractures are 2 or fewer pieces, because an incomplete fracture is still technically just one piece.
Okay.
Good question. Everybody see the spiral versus the oblique? The hint could be in the x-ray, the hint could be in the vignette. So use both to your advantage. That's it for the humerus. Right? It's only a couple ways it's going to break, and usually it's either a comminuted or a simple fracture, and it's going to be in the shaft of the humerus. That's pretty much it. Because then the other abnormalities we either talk about in the shoulder, right, with the hill sacks or the vein cart, things like that, or we'll talk about in the elbow. So here's the elbow. Here's the anatomy of the elbow. Here's the x-ray of the elbow. This is where we have the coronoid. Right there. Not the coracoid. Coronoid. Read carefully. Okay. Got our radial head. Got our lectinon process. The capitulum that sits in here. The trochlea, right? All kind of together. And then what I've outlined here is the areas of concern that I want you to view. This is normal, but this is the area, the red rectangular box area, is the area that you need to pay extra close attention to when you're looking at a shoulder x-ray, or sorry, an elbow x-ray, apologize. That's where that posterior fat pad sign is going to be. So after you do your systematic process, when you get to that soft tissue area, really look to see if you can see something. There is nothing here. Right? This is normal. But when you see that posterior fat pad sign, it's likely a fracture either somewhere here in the humeral head that is super subtle that you can't notice, or it could be anywhere here within the olecranon, on the process, within the trochlea, like the coronoid even, and it's just too hard to see. And that's why after you do your process, like I don't see anything through the cortex, I don't see anything through the medullary, but when I get to my soft tissue, I need to look for that posterior fat pad sign. Let's say that again. Posterior fat pad sign. Yes, the anterior sail sign is also considered abnormal, but in the level you're at right now, without seeing a bunch of these, the anterior fat pad sign is going to be present in almost all the x-rays. So it can be very easy to get that confused and playing that game and going, is that normal? Is that a sail sign? I'm not really sure. Just look for the posterior one. Posterior one is always abnormal. Always. So that way you don't have to worry about the shape of that anterior one at this stage. You'll get better with that as you see more of them. This is your AP, your normal radiograph with your anatomy. Notice how the radius and the ulna do overlap. So when you're tracing the cortex, often what we'll get is you're tracing the cortex, you're coming around, you'll be like, oh, I see a break like right here. Nope, that's the shadow of the radius coming down. Oh, I'm tracing my cortex. Oh, look, there's a fracture line right there. That's actually just the shadow of the radius coming down, which is why it's important in the ulna to trace these bones. Trace them all and know that this is the radial head coming in here, creating a little bit of a shadow when it's overlapping the ulna. That's what that is. It's not a fracture. Also why it's brighter white here, more radial opaque here than it is with the rest of the cortex, because you have overlap of the radius and the ulna together. They're sitting on top of each other. What are all those red arrows? There's two hints here. One, it says it's normal.
Growth plates.
Those are your growth plates for a pediatric elbow. Look at how easy that looks like it's a fracture on these epicondyles. Those need to fuse as well. These are your growth plates on a pediatric elbow. Not, this is more for when you see them in clinic, you're like, oh, that's a fracture. Not necessarily, right? Exam-wise, I'm not going to give you a pediatric one and ask you where the fracture is unless it's like, none of the choices are going to be lateral epicondyle, medial epicondyle, right? That would be unfair because you don't know when they're supposed to fuse. I don't know when they're supposed to fuse. I have to look it up. Here's your pediatric lateral elbow. That is normal. That's normal. Radial head growth plate, normal. Growth plate down by the trochlea, normal. But what I do like about this film is just like we showed in the AP, another example of the lateral and that overlap, right? That overlap here. This is not a fracture of the ulna coming down in here. This line, this is the shadow of the radius coming in. That's where these upper extremity ones and a little bit of lower extremity get a little confusing because these bones start to overlap and it's not clear cut like that humerus, but like it's just right here. So when you think you see something, go back and trace the bone. If it lines up with the bone, it's not a fracture. And the question I'll usually get, like, well, what happens if there is a fracture? Directly where it lines up with the bone? Well, then nobody's going to fault you for missing it, and that's why we get multiple views, right? Because if there is a fracture right here, it'll probably show up on the AP in a different spot that doesn't happen to just overlie the radius in this position. That's why we always get multiple views. And if for some reason, in the most obscure, unperfect world, that the fracture lies right over the shadow line of the bones overlapping on both of the images, nobody's going to fault you for missing that because how did you see it? It's not there. I just assumed it was bone shadow. So don't get hung up on the little intricacies of the what ifs of 0.2% of possibilities. This is a special view sometimes they can get, right? So what if this goes into my subway load? What if there's a fracture right here and I couldn't really tell? Well, if you're really concerned about it, you can ask them to get a 45-degree angle view and really open up that radial ulnar joint to actually do your tracing and find out. This is not standard. This is something you'd at the special have to order. And so that's what the answer would be in clinic. I'm not going to do that here for this exam, but that's what the answer would be. Like, hey, I'm not really sure. You're hurting. You're pain in that area. Let's order something like this so I can actually look at each of those bones in that joint area and make sure there's not a fracture. So it elongates those joint spaces from the angle that it's in to allow you to view the entire bone. You can get creative with these things sometimes. Normal CT? What's going on here if it's normal? Why is that so thin? Can I have a guess? It's just the slice that I'm showing you. If you were to scroll in and out more, you would end up seeing one that has full thickness just like this x-ray. It's just the slice that I'm showing you. That's all. So what kind of question would this have? I'm going to give you something like that looks really funky. It's going to be pretty simple of what modality and what slice is this. All right, I'm not going to have you plot an abnormality on something that I don't give you a full thing.
Would this be a sagittal slice? How are they positioned?
What would it
It's
be?
like, it's like this.
Does it matter? So we base our slices off of what? Not how they're positioned for the exam, but normal anatomic position. So even if they're like this, right, or for whatever reason, normal anatomical position, this is a lateral view, which means it's going side to side. It's a sagittal slice. And I'll be watching you guys throughout the test, doing this, at your desk, and trying to feel your different bones and figure out how things move. That's just like AP last semester, as y'all did that, I know. I proctored a couple. I was like, oh, upper extremity. It's okay, do that, right? It's fine. But yes, remember, slices are always normal anatomical position. Uh-oh. Uh-oh. Name it for the distal segments. First glance, whoa. That's anteriorly dislocated. First glance. No, it's not. Distal segment is posterior compared to the proximal segment. That is a posterior dislocation. Don't let your eyes trick you. Because your brain wants to say, well, that's supposed to be here, so clearly it moved up and out of the way, so that's what happened. don't know. That could have happened, or what's the big red arrow could have happened. I don't know how it happened, but that's why we have our naming techniques. This is a posterior dislocation. So we don't name dislocations for anything about the bones, right? Remember, that's going to be your displacement. Dislocations is just joints. So you would just say a posterior elbow dislocation. That's what you would say. If you were explaining this to ortho or another provider, I have a posterior elbow dislocation. Now, if it was a fracture, and we're talking about displacement, that would be different. We're going to name the bones that are involved. If it is both of them, and they both have the same description, it would be appropriate to say both bone for the forearm, right? Or you can just say radius and ulna, whatever the case may be. But this is just a joint, elbow dislocation. Big fracture on the olecranon, okay? See if your eyes can pull out the posterior fat pad side. You know, I've circled it. Don't think it's circled on your slide intentionally, so that way you can try to find it and see if you see it. Most of the time when you need to use your posterior fat pad side, the fracture will not be this obvious, because we're using it to ensure that if there's a fracture we can't see. I use this one to show you that with all fractures in the elbow, you will end up with a posterior fat pad side because there is bleeding going on. All fractures have bleeding. You've broken the bone. It's going to bleed some. Does everybody see the posterior fat pad side? You see that radiolucency right along the cortex of the posterior humerus. Okay? Not for this one, you don't. You have maybe. There you go. There you go. Right? So that's what you're looking for. Look at my normal one next to it. Zoom in on that. It's not there. Right? Sure, you get really good at this. Look, I can see my anterior fat pad here on this one. Oh, is that a sale sign? Is that nice? I don't care. Is there a posterior? There's not. I'm not worried about a fracture. Moving on. Right? Don't get hung up on that anterior sales sign. Ortho will talk more about it. They really like it. But they look at way more of these than you guys do at your level when you're in primary care. So they can tell you right away, oh yeah, that's a sale sign. Look posterior, guys. All right. So now jumping into that radial head fracture. We have belabored this enough, and so since it's going to be quick, and I just realized what time it was, come back at 3 after. And I guess they moved our lab from Monday afternoon to Tuesday afternoon. Did you see that in the schedule today? Am I tracking that right?
Correct.
Yeah, he's still doing special ball tomorrow.
Okay, but the last update showed that it moved to Tuesday afternoon at 1300 that I have. Because they've been moving, for some reason my phone, I don't know why she didn't radiology so much, but we keep moving our stuff around. So we'll keep an eye on that. So right now what I'm tracking is the lab Tuesday afternoon at 1300. And then we will look at the schedule. I'll get with your class leader. It will be sometime probably on Wednesday. We'll do that optional Q&A review. The reason I do it like on Wednesday is because the lab is the lab, right? It's going to give you practice. But our last lecture is Monday. That gives you 2 days to care about me since I'm Friday, right? To really have an understanding of what you understand, what you don't understand. And then we can have that review and that Q&A on Wednesday, which then still gives you 2 days to kind of get ready and kind of brush up on anything for the exam. So I don't like to do it really close to the last lecture or really close to the test, because that's just not ideal. So, all right, jumping back into radio, yes?
For expectation purposes, so Wednesday, just Q&A, there's no...
Yeah, I don't have so the blue slideshow you can use on your own type thing, right? I used to be like, if you don't have questions, I'll go through the blue slideshow. And I was like, well, that's just a waste of everybody's time because you have them. You can go through them yourself, right? So what it's primarily used for, I don't have a test review, because what I have found when I have done that is it sets you guys up for failure in the aspect to where the assumption becomes, well, if it wasn't in a test review, it's not important, right? And then I don't put it in there, like, well, you didn't put it in the review. Like, it's all important, right? So, and then I feel like I'm insulting your intelligence by just sitting over here and reviewing and going over things that you all may understand, right? So I've just turned it into like a full Q&A. I'll have all 8 slideshows on my laptop prepped and ready to go. So any confusion you have on any topic, on any questions or anything, you just go around the room, and if you have something, raise your hand, be like, hey, slideshow number 3, slide number 17. I'll pull it up, ask your question, I'll answer the question. Usually that ends up stemming other questions, right? And we try to clarify anything. And for the most part, I'll stay until like we're done. Like, I mean, if it's over lunch and there's a lecture at 1300, then I have to bounce. But like, if we end up doing it like at 12 and there's nothing at 13, I'm like, I'll stay until you guys are happy and good, right? I'm good for you guys. And that'll be here in person. Did that answer that question?
Yes.
Okay. Other questions on that? No, we're getting close to the end of the block. All right. Radial head fracture. So we belabored this over and over and over again. So I'm not going to spend a whole lot of time. We're starting to get to that point of kind of brushing through. Etiology, fall and outstretched hand or direct load of the lateral elbow. Okay? Tenderness over the radial head, localized swelling, pain on the forearm, specifically with rotation or flexion, those things that move the radial head, right? X-ray is your study of choice. Yes, you have the sale sign, but it's that posterior fat pad sign that we've been talking about. That's what you're looking for mostly. If it's there, it's an abnormal X-ray, even if you can't see a fracture. If you don't see a fracture and it's not there, then you can be confident in saying that it's normal. Now, I had a good question on these guys here, right? And they're like, well, hey, will you always see a posterior fat pad sign with any fracture on an elbow X-ray? And I said, no, but here's why. Look at how much bone I have on an elbow X-ray. If I did a fracture up here in the humerus, or like down here in like the radius of the ulna, look at all this space I have for the bleeding to go, right? It's not confined in this small little area of the elbow. So I'm not going to get a whole lot of blood pushing up on a posterior fat pad, right? That's for those occult fractures primarily within this centralized elbow joint area. Radial head, olecranon process, trochlea, capitulum, those areas within that elbow joint. That's what pops that positive fat pad sign. Why is that important? Because these are the areas that are hard to see because there's so much overlapping bone there. It's very difficult to find all the fractures. That's why we use that. But if I get one up here or down in here, it's very possible you don't have a posterior fat pad sign. But then I would argue that if I have it up here, that's a humeral fracture, not a fracture of a bone within the elbow joint, right? If I have one down here, that's a radius or an ulna fracture, not necessarily one with a bone, area of the bone involving the elbow joint. Does that, right, help understand kind of what we're looking at? So I've outlined another posterior fat pad here and a radial head fracture for you. Again, on your slides, I don't think it's outlined, so it gives you a chance to kind of look at it and try to outline it there. Do you need the posterior fat pad sign to find the abnormality on this X-ray?
No.
No. No. It's right there. So you don't have to look for it. You look for it when you don't see a fracture and you want to make sure there isn't one you're not seeing. Here's another good example I like about this slide. I have a right and a left elbow that are pointed in the exact same direction. This is why you have to have the markers on the bottom to tell you if this is right or left. They look exactly the same. My left is flipped. That means before they sent you the X-ray, they flipped it so it would be in this direction. It's still a left elbow, so it shows all those things I was talking about, right? So when you're dealing with bones or parts of the body that look the exact same right from left, you cannot tell the difference without a right or left marker on there. On the exam, if somehow one gets slipped through and there's an elbow or a wrist and it doesn't have a right or left marker in there, the vignette will say the patient comes in with right wrist pain. It's a right wrist. Right? So I try to find ones with markers, but every once in a while one gets through. But if it does, the vignette will tell you why they're coming in. I'm not going to give you a left wrist X-ray when the patient comes in with right wrist pain. Like that doesn't make any sense. That's not what we're here to do. All right. Lots of examples of posterior fat pads. Now I like this one because this is one of the ones that actually shows a really nice anterior fat pad of the sale sign. But again, posterior fat pad. The red circle is the small, itty bitty radial head fracture. Right, if you say so. I agree with you, right? A lot of you are probably going to miss that, especially at this stage. But if you look for the fat pad sign, you'll know there's supposed to be a fracture. That's what I want you to get out of this. No?
Previous slide, you can see it.
But if I'm looking at these, how would I?
Questions? Lots of sidebars. Yeah, you can zoom in, right? This is part of the reason you're allowed to zoom in on the exam. That being said, don't trick yourself. Don't overread. Don't make something there that's not there. Look at your answer choices first. Figure out if I even want you to look in that area. All right? I've seen people spend a lot of time, I walk around, I see people spending a lot of time on areas of x-rays and the answers have nothing to do with that area whatsoever. Right? Use your time wisely. Look at what I'm asking for first. Because I can't ask you to point out 6 abnormalities on an x-ray like you're going to have to do in clinic. Because from an academic standpoint, it's just not possible. There's not hidden bonus points, correct? Yeah. It's just that little notch. This right here? No, it's just that little notch. It's likely coming over in here, right? It's likely coming this way, but I can't tell on just this x-ray. So here's how you can tell that this line right here that you're talking about is not a fracture. It's got a, where's the connection? I have no line, no black line going from the notch down to that line in the medullary. Like with that gap. So I'll buy, and I have a little thing, the line coming down here, but then I have this gap of medullary here that doesn't have a black line connecting the two. Fractures have got to be connected if they're from the same area, right? The energy doesn't like jump a hurdle, right? I fractured the head, and then, oh, I didn't hurt this part of the bone, and then I hurt this part of the bone, right? It all goes in one direction. So I can respect that, and that's what I'm talking about with like the overread stuff. And in reality, does it really matter? If that was the fracture in this elbow, if that was the same for this court, you found the fracture. You got the posterior fat pad, we're good, right? So, and in clinical and radiologist read to kind of help you out with that too. So how would you do that? Let's say this report came back, not that one. Let's say this report came back normal from the radiologist, right? Let's say it did. This is a really fine abnormality, right? Very small. But you saw this line. Or maybe you saw the notch. And you're like, I totally thought it was fractured. I told the patient, like, hey, this looks like a fracture. Let's put you in a sling. Let's get you better. And the report comes back and it says it's normal. What do you do? Okay, so call the patient. Well, you said, but you're going to call the patient and tell them that you made a mistake and it's normal?
No.
Come back and let's get another one. I'm okay with that. What's something you can do right then and there to verify what's going on with the findings? Call the radiologist. Call the radiologist. How are you going to do that? Hey, sir, ma'am, I think you screwed up and you suck at your job. It's like, I see a fracture. You said it was normal, right? So I've had to do this before. The way to do that is play dumb, right? Because the odds are, you guys, you found a fracture and they missed it. If you see something and it comes back normal, and it will happen, the odds are you found it and they just missed it. Why? You had the opportunity of seeing the patient in clinic. You knew exactly where they hurt. So when you were reviewing it, you looked more closely at some of those areas than they just had this picture with no patient in front of them. So you call the radiologist, hey, sir, ma'am, I was looking at the x-ray on patient Smith or whatever. You read it as normal. Like, yeah, like, well, I was looking at this radiolucency that's sitting kind of right at the edge of where the radial head and the ulna overlap, and there's a small notch on that portion of the head. Like, am I seeing something there, or are my eyes playing tricks on me? Right? You're kind of like, I think I see this. I want you to tell me why this isn't an abnormality. Make me smarter. Usually they'll look much closer and they'll be like, oh, you're right, that is a fracture. I'll amend my report. Or, if you're off, they will explain to you what that is. Hey, no, that's just normal, bony trabecular pattern. That's not a fracture. Here's why. I don't have that gap kind of there from where you're looking at, or they'll explain it to you. They will help you with that as long as you're tactful about calling them. And then within 30 minutes, you get a ping on your system. The report has been amended, and it says radial head fracture. So you will have to do this at some point in your career, probably multiple times. When I was full-time family practice, I think I probably did it at least twice a month. Hey, this looks broken. So, all right. CT or line?
CT.
Beautiful. Which bone is fractured?
Ulna.
Ready. Perfect. Ulna. How do I know it's the ulna even on just this one slice? So it's a little bit bigger, but primarily it's wrapping around, right? I got my capitulum and the olecranon process is coming around the trochlea right here. That's one way. Simple, comminuted? Comminuted, I can see just from this slice, I got at least 3 pieces. Could I have more? Sure, but it's more than 2. And that's all I need to do to define it. So I got a comminuted ulnar fracture. I can't tell you left or right because I'm not the one who ordered it. There's no markers on CTs, but you'll order it so you'll know if it's left or right. Do we recall what this fracture is called? Yes, it's an avulsion fracture. The triceps comes in right here on that olecranon area, ripped it right off. It almost looks like a puzzle piece. I can just plug it right back in there and glue it right back in. Good. What's circled and fractured there? Not the, like this, I gotta fix these. Not that one, but this one. Coronoid. It's the coronoid process. Not the coracoid process. Questions on the elbow and the fat pad and all that fun stuff. All right, forearm. Anatomy on the forearm. Anatomy of the forearm. Same thing, joint above and below. All my forearm x-rays better have wrist and better have elbow in it. If it doesn't, I need to repeat it because I need to be able to see both the radius and the ulna. Here's my lateral view. We've already looked at it ad nauseum, the overlapping of the radius and the ulna down here. And you end up having it almost completely superimposed up by the wrist. The pediatric one, with all those growth plates. And a pediatric lateral. Not a fracture, it's like a non-process. Okay. Again, notice how I have a right forearm and a left forearm, and they look exactly the same, minus the fractures. They look exactly the same. Cannot tell the difference. I need a right and left marker to determine it. But if you go through your method, right, so what kind of fractures do we have here? So both bones, sure. Complete, I'll take complete, that's one word. What else can we use to describe it? Shortened, okay. Position-wise, I'll take shortened. What location? Mid-shaft, okay. You do both bone, or you say mid-shaft, radius, and ulna. Either one will be okay. Let's take a look.
Is it spiral because of the depth?
I only see 2 pieces, and here's why. I would need the lateral. I see what you're looking at. What I don't know is this fracture line here on this picture, is that its own piece, or is that still connected to that piece? The lateral would tell me more. So I see what you guys are looking at. For those asking, if the ulna is comminuted, it looks like there's an additional fracture line right here at the tip of this portion of the bone here. But right now, it looks like it's in line with it, right? It's not displaced, it looks like it's in line. So it very well could be on the other side still connected, which then still makes it a symbol. So if I gave you just this picture, I would have to say they'd be simple fractures. But if you had a lateral that showed multiple pieces, now you can make the ulna convoluted. So, good way to look at it. So we would say transverse fracture here for sure if we wanted to. And a question I had on the ulna is it spiral? Borderline. There is some depth there, right? So what would I kind of want? I would want maybe a mechanism of injury to help confirm that. It's not as obvious as some of the humerus ones we've seen, as some of the other spiral fractures we've seen. We're going to see the tibia too on Monday. So I would want a little bit of information. If I had a twisting motion, then I might consider it. What leads me towards maybe not is my radius isn't spiral fracture for sure. And the odds of spiral fracturing an ulna and not a radius is pretty rare because they probably have the same mechanism of injury. But I recognize that, so if this was a test question, really the answer would just be a mid-shaft radial ulna fracture with shortening. That would be the kind of thing I would be looking for on this particular one. I wouldn't even make spiral a choice, because I didn't even make transverse a choice, because I have a transverse radius, and if it's not spiral, I at least have an oblique ulna, so I got two different ones. I would just kind of just call it simple radius ulna with shortening. What do we call this one? This one has a pathognomic name. I'm okay with oblique. Nightstick. I briefly mentioned it. This is that nightstick fracture. This is not a green stick because it's not pediatric. If this was a pediatric film, it would be a green stick fracture. And you probably see more bowing or bending around the edge of the ulna in this particular case, right? But this is an incomplete, simple, right, ulnar fracture, aka nightstick fracture. Good. What do we call this fracture? Torus fractures. Kids are bendy. That's it for the forearm. It's kind of like the humerus. It's pretty straightforward. It's two long bones. There's only so many ways they can break. And really, you just got to know how to look at it and describe the type of fracture it is and which bone it is. There's not anything super fancy about the forearm. There's your wrist anatomy. Not testing you on ligaments and all that other kind of stuff. There are certain carpals you need to know, right? Alignment. This one I want you to know. This is what we were talking about before. Look at your carpals and look at how your pisiform and your triquetral kind of sit over each other, and then even a little bit on the hamate, a little bit on the lumate. So this is why some of those areas of the wrist end up being more radial opaque than others, because they're overlapped. If you understand the anatomy in that aspect, then you'll understand why that is, and you won't think it's an abnormality. Okay? Right? So right in here. You got your pisiform, your triquetrum, right? And then the biggest one that people get hung up on is the hamate. That's the hook of the hamate. It's superimposed over the hamate. That is not an abnormality. That is not a fracture. That is not a weird growth. It is the hook of the hamate. And then your trapezium and your trapezoid always overlap each other on that PA film as well. So understanding how your carpals lie will help you understand if what you're seeing is actually an abnormality or if that's what it's supposed to look like. We do our lateral. The nice part about the lateral is the lateral will tell you, because look at all these carpals and kind of how they're sitting together, and they're all kind of mumbo jumbo, right? Any one of these guys can get dislocated. Most commonly dislocated carpal bone is what? No, that's fracture. Most commonly dislocated carpal bone. You remember from A&P? It's the lunate. Why is it the lunate? Look at how big the capitate is. When you fall, that giant bone pushes down on the lunate and dislocates it. Right? Well, how am I going to see a dislocation on a carpal? On the lateral. All the carpals sit very nicely right in here. They all superimpose each other on the carpal, except for a little bit here of the pisiform that comes out, right, in the scaphoid. But down here, everything sits nice. So when your lunate is dislocated, it pops out right here anteriorly. It sits out right in this area. or ventrally, really technically. So this is a really good x-ray to use. Sometimes we check for fractures of the radius of the ulna down here by the wrist, right? Make sure those align or are superimposed very nicely. Make sure they're not dislocated, looking at where they're supposed to sit along with the carpal bones. But really the nice thing about this is you're looking for a lunate dislocation on that lateral of the carpal bones. Because in reality, looking for fractures, with all these bones superimposed on one another, it's almost impossible to see the fracture. You're looking for displacement or dislocation on this lateral wrist. Because the fractures you'll see here, or here on the oblique. So if you remember, on the PA, right, my trapezium and trapezoid are kind of superimposed on one another, but when I go to my oblique, I pop open those joint spaces now, and now I can see the full trapezium, the full trapezoid. I can see that tricretrum really nice. I don't love this one very much. That rarely fractures or dislocates, right? But I can pop out those carpal bones now, open up those joint spaces, and be able to see the full cortex, primarily of these guys over here by the scaphoid. That's why we do the oblique wrist as well. It's just like a 15-degree rotation. It's just enough to pop those guys out. You'll get all three of these in clinic when you're doing it. Another one I like for the oblique wrist is you get a good look at that ulnar styloid. This is another area that can easily be fractured, right? And this view will really show that. Oh, I was supposed to take that slide out. I didn't. Don't worry about that one. Moving on. All right. So we got a CT here. What's going on with the big red circle?
Part of the radiation.
Is it fractured? Nah, it says normal CT. It's a slice. It's a slice again, right? Show you these over and over to not get hung up when you're studying the slide trying to find the abnormalities. It's just a slice. I will give you a slice that has everything you need to answer the question that I'm asking if I give you a CT slice. Okay? If I give you something like this and I want you to find an abnormality that's somewhere else, I'm not going to give you a distal radius fracture, right, as a choice, because in this slice, how can you tell? You can't. So you want to be evaluating that part of the radius. If you look at your answer, you knew what I was looking for. This is a normal CT, it's just one of the slices. You can see how nicely we can see all of the trabecular pattern in the bone and the cortex and really evaluate those carpals if we need to. Normal wrist. Fracture of the distal radius. Intra-articular, so it's going into the joint. What type of Salter-Harris is this? I heard 4, I heard 2, I heard not. Not. This isn't a pediatric patient. There's no growth plate. You can't have a Salter-Harris. But it's not. I don't know, because I don't have a growth plate, so I don't know where the epiphysis and where the metaphysis is. I don't have a Pisces anymore. So that's why I can't do it, right? Because without an epiphysis, I can't tell you what type it is. It's not. Anybody else notice any other abnormality on this besides the fake Salter-Harris fracture? I think I heard it. See that ulnar styloid fracture right there? Ah. It's supposed to be here. Ah. No, it's over there. That's a problem. So this would be an intra-articular distal radius fracture. It's right there on the slide. Why is it intra-articular? Because it involves the joint. Any fracture that goes into a joint is considered intra-articular. Ortho will talk more about that. That's really important to them because when you involve a joint, you potentially involve functionality, and they really like to know that. They will teach you more about that next semester. Let's do some more practice. Now, what kind of Salter-Harris do we have? Because it's pediatrics. Look at all the growth plates. Look at all the growth plates in the fingers. Right? I got growth plate here, got growth plate here. I got all these growth plates. all these growth plates. So I'm hearing one. I'm hearing one. Don't mob me after class. I'm hearing two. Just start saying numbers, yeah. Please don't say five, because somebody's not going to make you find five. It is a Salter Harris 2. Let me show you why. So first, I appreciate the fact that a lot of you are looking at the edges, okay, and trying to line it up. You're saying, hey, it looks like it might be slipped, which is that one, right? But if you go through your whole process, what you will see is the fracture comes across and right here. See that little fleck right there? That's part of the metaphysis. It's not just through the growth plate. It's through that and it comes up here. It's still attached here. This is moving. That's technically a tube. That is part of the metaphysis through the growth plate and away. I think if you use your lateral here, if you use your lateral, you will see that it really doesn't look like it's slipped very much when you use both x-rays together. That's all pretty in line there. But then on that PA1, I have that metaphyseal area right there that's fractured up. Does everybody see how it's pretty much in line here on the lateral? This is one of those things where sometimes you have to use both the images to kind of piece it together like a puzzle while we give it to you. No, don't get hung up on which finger this is.
Oh, no,
Okay.
It's down here on the x-ray, not up here. It's this
Yeah,
way.
right here.
It's down here.
Right here.
No, it's never
One.
down.
Oh,
Yeah.
yeah. Process still falls.
It's there.
Not down here, no, you can't make out the metacarpal phalangeal joints on the lateral.
Yeah.
Yeah, you can't make that out.
Yeah.
I will still use that term. It's a 2.
Yeah.
It's a 2. Really what the point was to try to show you, thank you, I will fix that, was to try to show you to use both the images together when you're looking at it. So I apologize for that, that is on me, that is a good point, that is the metacarpal phalangeal joints in there. But does everybody see that it goes up into the metacarpal? I know, don't mob me afterwards. Right, that's how subtle some of these ones can be. What's going on here? How do we think this patient hurt themselves? Foosh. So if we're fooshing, what are we concerned about? Scaphoid fracture. So you can see it right there. First big green arrow, right there. This is showing you the increased signal, so we call it on MRI increased signal, to know that there's inflammation and fluid kind of going on within the scaphoid, trying to heal itself, but there's the fracture right there. That fracture likely missed on x-ray a couple of times because it's so finite and so small. This is why we'll do the MRI will pull it up. But really, knowing that that's the scaphoid, foosh injury, you guys are on the right track. This shows you that blood supply that we've talked about. It's just kind of showing you why we're concerned about the scaphoid, how it just has that one-way blood supply and it doesn't really have another one, which is why we get so concerned about it. All right, so all of these bones here, all these carpals are healthy, nice and healthy under the MRI. Very, very good. Capitate, luminate. But then I take a look at my scaphoid. Here's the fracture line right here. Again, I know the colors aren't on your slide, so it's good. Here's the fracture line right here. And this bone is starting to die. I do not have any blood flow to this piece. I have some up here, it's good, but none down here. All right, because look at the anatomy. When I fracture it, the idea is that the blood comes in superiorly here on this picture and feeds the rest of the bone. So when you fracture down here, I have no blood supply down here, and that's why I get concerned about it. I That's why I just want you guys to be able to find the abnormality. Bless you. More pictures showing you the x-rays compared to the MRIs. Maybe? I don't really see a fracture line up there, right? It's slightly more radiolucent from the rest of the scaphoid, but maybe not when I compare it to the other carpals, so I'm not confident that I can call a fracture on that x-ray in alpha. I'm really not. I definitely don't see a fracture in Bravo, because I already told you, like, the carpal bones is not a good way to see a fracture. If I go down to Charlie and I kind of try to analyze it on the oblique and look for a fracture on the scaphoid, going down to Charlie and doing my method, not much, right? I can't pull that out. Same thing with Delta. Following my method, if any of you think you see the fracture, please let me know, right? I've had people before pull ones out that I haven't seen. But this line right here is actually the shadowing and the overriding of the two carpal bones, right? That's not a fracture right here. That's the two carpal bones kind of overlapping one another. The x-rays look good. Now look at my MRI. Look at echo and look at Foxtrot. That's why this will be the study of choice. That's why after 2 trips, if it's still not better and your x-ray is normal, you get this. Yeah.
How long would it take for you to start seeing the sclerosis of the scaphoid?
I don't have a time frame for you. It takes a while though. Somebody asked that beforehand too, so and I kind of think I get what you're saying, right? Like, I want to see the sclerosing. Usually the sclerosing is something that has been missed and you're finding it really late already. That bone's already starting to die. So it's going to vary by person. I don't have like a specific time frame. But if you follow the method we've talked about with the x-ray normal, 7 to 10 days, x-ray normal, 7 to 10 days, I'm going to order MRI. MRI probably going to take a couple of weeks. It's not within like 6 to 8 weeks. It doesn't happen that quickly. Yeah, good question. All right, so here we have a weight-bearing view of the wrist. All you're doing is clenching the fist, right? You're applying weight as if you were twisting a wrench or something like that. And what we're trying to view is we're trying to figure out if there's a disruption between the scaphoid and the lunate. So here is your normal clenched view x-ray on the right, or sorry, the left, your left. Look at your joint spacing, nice and same, nice and thin and small. And the nice part about scapholunate disassociations is that these are rarely bilateral. Rarely bilateral. So when you get the clenched view and you're doing your analysis and you're looking at joint spacing, the abnormal one will stand out because the scaphoid and the lunate will separate from one another. This is going to be surgical. They're going to need to surgically fix this, or we'll talk more about that. But if you're concerned, i.e. pain in that area, in the carpal area, you get these instability views. It's like a pen tip. So we see that was a little arrowhead. It's either a ring with something metal in there or like a little pen tip. Questions on the wrist. Mostly with the wrist, guys, is that scaphoid. Right? This isn't, this you want to find too, but wrist is mostly the scaphoid and making sure we don't miss any of that stuff. Hand anatomy. A lot of muscles, a lot of tendons, great. Okay. We've seen these x-rays before. We know the anatomy of the hand. We know to go through our process. Again, primarily lateral, just like the wrist. Really hard to pull out fractures, but what a great view to look for any kind of displacement or dislocations, because everything is supposed to be superimposed on one another. Now, when we're concerned about a certain finger, like the one we saw, they will pop that finger out and take a lateral like this, or pop the pinky out, or pop the one digit out, right? They will do that, but usually when it's just a whole hand, they'll just superimpose everything together. So you can just make sure everything lines up the way it's supposed to. Pediatric hand, right? What's that? Sesamoid, normal variant, not an abnormality. common. If it's not painful, we don't care. We're learning about sesamoiditis and ortho. So the thumb, we end up having, this is actually an oblique view because of the way the hand sits. If you set your hand flat on your desk, take a look at it, you notice how your thumb is kind of at an angle naturally. So what they do is this first view, even when you do like this hand, right, or this hand, everything's in a PA flat view, but the thumb's actually on an oblique just because of the way our anatomy sits. So when we're trying to do that, we'll get that one. And then if we want to see the actual like frontal view of the thumb, they flip it out like this, and they'll shoot straight down, and you get that nice frontal view of the thumb. Thumb is really easy to separate from the other fingers, some are not. Okay. So let's look at these images. There's a lot going on here. Each one's a little bit different. So I heard one of them being incomplete. A couple that are complete. Probably some simple, maybe some common muted when you look at the fourth one, right? So with all these abnormalities going on, the simplest way that I would just end up describing it, or if I would ask you this on a test question, would be fractures of the second, third, and fourth metacarpals. That's it. Here? Yeah, good question. So here's my normal. It's close, right? Not sure. So what I would do on that, right, if I was with the patient is the patient hurting in that area? Is there any issues with that? If they're not having any issues in that area, no pain, then I would say it's normal, right? So if this were a test question, right, and I wanted you to pull out the abnormalities, I could do this multiple ways. One is straight up forward, simple, second, third, and fourth metacarpal fracture. Or I can have one correct answer and have a second, simple, incomplete metacarpal fracture, and the other choices be things that aren't going on, like a fracture of the fifth metacarpal could be a choice, right? Or a transverse fracture of the third metacarpal could be a choice, because that's not transverse, that's oblique. That makes that not a right answer. You see what I'm saying? So I can pick out one of these, even though there's more than one abnormality, as long as all the other answers are clearly incorrect. So it just kind of depends on how that's set up. Which is why I say look at your answers first. Know what you're looking for.
I need an MRI.
Unlikely. What would an MRI look for? Let me ask you this.
You can't have a lateral view, right?
Sure you can. We'll just turn the hand lateral. It'll be fine. But let me ask you this. Is an MRI, or the results of an MRI, if you don't know yet, that's okay, right, going to change your plan of care? If it's not going to change your plan of care, there's no reason to get it, right? So as a provider, that's how I want you to think, right? If the lab that you're going to order or the radiological imaging that you're going to order isn't going to change your plan of care based on the results, then there's no need to order it. Save yourself the work, because you have to answer to everything you order, even if it's normal. You have to respond to it. Right? So checking a CBC doesn't change your differential, and you're not going to change what you're going to do for the patient based off of it, i.e. a specialist or a different treatment. Don't order it. So I like the thought process, right? You want to ask yourself, do I need an MRI? Next question should be, will that change my plan of care? Whereas something like an ACL tear or meniscus tear, if you find it, yeah, that would change your plan of care. So if you suspect that, you need the MRI, because that's going to change what you're going to do for the patient. All right, boxer's fractures. Fracture of the fifth metacarpal. Typically near the head of the metacarpal, not always, but typically here. It can also be the fourth. Fifth is what I want you to know about that. X-ray is your study of choice. And how do you get this? Why do they call it a boxer's fracture? Because you punch somebody. And this is the one that comes in, they said, oh, I tripped on the curb. You fell like this? Like, how did you, like when I trip, I don't fall like this. I put my hand out, right? And that's where you got to convince them to tell you what really happened. Because you need to know odds are it's probably an open fracture. You know, was it a wall? Was it a human tooth? What was going on? So, boxer fracture, right at the head of the 5th metacarpal. It absolutely can be the 4th as well, right? A lot of times you'll see that on deformity on physical exam before you even get to the x-ray. All right, we're almost done, guys. A couple of fun ones to talk about. Bennett fracture. So, boxers, head of the 5th metacarpal. Bennett, base of the 1st metacarpal involving the joint, intra-articular, right here. Okay? It's a simple oblique fracture at the base of the 1st metacarpal. Simple means what? 2 pieces. Bennett has 2 ends and 2 T's, so it should have 2 pieces. Okay? Here's why I say that. Rolando's is a comminuted fracture that is intra-articular at the base of the 1st metatarsal. More than 2 pieces. I drew all over it to help you. I know your slides don't have the drawings on them. But if you look, there's this fracture here where I drew this out, and then there's another one right down in here. Right down in here. Next slide down. Okay, just making sure. So that's your Rolando's. So Bennett, 2 ends, 2 T's, 2 pieces. Rolando's more than 2, comminuted. Okay. Here's another slide that kind of shows it. It's not always in a Y shape like this one shows, but a lot of the times it is. Simple versus comminuted. It's got to be at the base of the 1st metacarpal, and it's got to be intra-articular. It's got to go into the joint. If I have a fracture up here, and it's not involving the joint, it is not a Bennett's or Rolando's, it is just a transverse fracture of the 1st metacarpal. These things have to involve the joint.
What's the MOA?
Multiple ways. Yeah, there's no one specific, like the scaphoid or the boxer's fracture. Multiple ways. Usually they're doing something with their hands, they get their thumb or something caught in something, they try to pull it out, it grabs, it pulls, it breaks at the base. That's usually what it is, some type of leverage injury, but not always. It's possible Rolando discovered it, I don't know that. What's going on here? Dislocation. I don't know which one's just based off of this. Actually, I think I do because I pulled the image up. Let me see my open notes. 4th and 5th. Okay, 4th and 5th. Carpal metacarpal dislocation. This would be a what direction? Dorsal dislocation. Remember, with the hand and the wrist, we use ventral and dorsal or ulnar and radial because posterior, anterior can be confusing, right? I get it, normal anatomic position, you'd be like, oh, you should know this. That's why we use dorsal. Just like for the feet, we use flexion and plantar, plantar and dorsal. Dorsal flexion, plantar flexion, because of the plantar part of our foot, just to make it less confusing than posterior and anterior. What we got there? Don't overcomplicate it. Yep. Just a distal, maybe oblique, maybe transverse, not too on that, but distal phalanx, simple distal phalanx fracture. Complete is fine as well. All right. In the interest of time, give it to you. Transverse fracture of the 4th metacarpal, mid-shaft. What must you order if you're going to evaluate AC joints? X-ray, right? But what kind? You said it? with and without weights, not just weighted. Because if you have just weighted, you don't know what normal looks like, right? Technically, if only one AC joint is injured, you should be able to tell when comparing them, but it's just with and without weights, and it's always bilateral. Questions? Bennett's 2 pieces, Rolando's 3 pieces, scaphoids, posterior fat pads, just kind of hitting some of the highlights. Have a good lunch. I'll see you guys down in lab. Well, like I said, some of you down in lab at 1. Feel free while you're doing that. If you have other questions, let me know.